All right, team, welcome to the masterclass. Today, we're tackling dilated cardiomyopathy. No time to waste. Let's get into it. Here's our flight plan. We've got the blitz, the disclaimer, a deep dive on anatomy, the 4 pillars of survival, a memory chant to lock it in, and then a look ahead. We're moving fast, so keep up.
First up, Section 1, the 28-second blitz. This is high-speed diagnosis. On the clock, go.
Dilated cardiomyopathy. It's the most common of them all. Think of the heart as a big, overstretched balloon. You've got these thin walls, huge chambers, and a pump that's just failing.
So what's the core issue? It's systolic dysfunction. That means the heart's ventricles, the main pumping chambers, they just can't squeeze hard enough to get the blood out.
Clinically, what does that look like? It means an ejection fraction, that's the percentage of blood pushed out with every single beat, of less than 40%, a critical number.
Causes? If it's familial, you're looking for that Titin mutation. If it's acquired, your culprits are alcohol, cocaine, wet beriberi, viral myocarditis. Know them.
On exam, what are you going to find? You're listening for that classic S3 gallop, and you're feeling for a displaced apex beat.
And the goal? It all comes down to survival, built on what we call the 4 pillars of therapy. You gotta know the balloon to save the pump. And that's the blitz.
Okay, pace change. Before we go any deeper, we must cover the mandatory medical disclaimer. Listen carefully.
This content is provided for educational purposes, specifically for the USMLE and international boards, and for these purposes only. It is not and should not be considered medical advice. You must always consult official guidelines and a specialist physician for any clinical decisions.
Right. Section 3, the balloon heart anatomy. Let's break it down. Sarah, we're not talking about thickened heart walls here. With DCM, we've got a dilated, weak pump. We call this eccentric hypertrophy. So explain to us the difference at the cellular level.
Of course, Dr. Collins. In dilated cardiomyopathy, the key is that the sarcomers, the fundamental contractile units of the muscle, are added in series. Think of it like adding links to a chain. This is different from adding them in parallel, which would thicken the wall. Adding them in series causes the chambers themselves to dilate, stretching the wall until it's thin and weak. The result? A catastrophic drop in contractility.
So the bottom line is, the heart can fill up with blood just fine, but it simply cannot push it out.
Precisely. Now you know the boards love to test genetics. So tell me, what is the #1 genetic mutation we see in this balloon heart?
That's going to be a mutation in the Titin gene, also known as TTN. It's huge. It accounts for about 25% of all familial cases. Titin essentially acts as a molecular spring inside the sarcomere. So when that spring is defective, the entire heart muscle loses its elastic recoil, which is what leads directly to that dilation.
Correct. Let's connect the dots to the physical exam. Why do we hear an S3 gallop? What's actually happening?
The S3 is that classic sound of blood rushing into a ventricle that's already overfilled and way too compliant, or floppy, during early diastole. It's often described as a sloshing sound. As for the displaced apex beat, well, because the heart is just so massively enlarged, the point of maximal impulse gets physically pushed over to the side and down.
Spot on. Okay, let's talk management. This is where the boards will really test you. We are way beyond the old days of just Lasix and digoxin.
Dr. Collins, Sarah, lay it out for us. What are the 4 pillars of guideline-directed medical therapy?
Okay, the 4 pillars, all proven to improve survival, are number 1, an ARNI, specifically sacubitril valsartan. Number 2, an evidence-based beta blocker. Number 3, a mineral corticoid receptor antagonist, or MRA. And the 4th and newest pillar is an SGLT2 inhibitor. These 4 classes are now the absolute foundation of therapy for any patient with a reduced ejection fraction.
Perfect. Now for our question of the day. We know that chronic heavy drinking is a classic cause of DCM. So I want to hear from you. Out there in your clinical experience, have you ever actually seen a patient's ejection fraction recover after they completely stopped drinking? Drop your stories in the comments below. I'm curious to see what you've encountered.
All right, let's lock this knowledge in for good. It's time for the DCM memory chant. Ready, Sarah? Let's do it.
Dilated is a balloon.
Systolic is the doom.
Titin is the gene. Dr. Collins and Sarah, S3 is the scene.
4 pillars for the win. Okay, balloon heart is locked, Titin, S3, and the 4 pillars. Got it. Excellent work. So we've mastered the overstretched failing pump. But what happens if the heart isn't too thick or too thin, but it's just hard as a rock?
Make sure you subscribe and join us for Module 3, where we take on restrictive cardiomyopathy, the concrete heart.